Hello and welcome to another episode of the SITREP. Today we are talking about the wonderful topic of diverticulitis. Doc, thanks for joining us again on the podcast.
My pleasure. Good seeing you again.
Same here. So diverticulitis, what is it?
So the best way to frame this is diverticula means an outpouching, and then itis is a general phrasing that's used for anything that's inflamed. So arthritis, arth is joint, itis is inflammation. So when you have diverticulitis, you're getting inflammation or infection of these diverticula. And then what are diverticula? So we all know what our appendix is. The appendix is sort of this vestigial portion of our colon that sits sort of in the right lower quadrant of our belly. And we're all familiar with appendicitis, which is the appendix that's inflamed. Diverticulitis is almost the same, although there's some subtle distinctions, but not everybody gets it. But for those that have diverticula or diverticulosis, they can get diverticulitis. And we can get into the details of that. But long story short, one cannot get diverticulitis without having diverticulosis, but not everybody has diverticulosis. So in summary, it's essentially an infection or inflammation of these little outpouchings that some of us can get as we get older. And there's a number of different factors that play a role in getting them. But it's a clinical presentation of an individual presenting with abdominal pain, typically in the left lower quadrant, in relation to those outpouchings that are getting infected or inflamed.
And so what are the symptoms of diverticulitis? Like, how do I know that? I mean, I don't want to diagnose myself, but how does someone know that they have it?
So to put this into context for things that a lot of us do experience with time is we've all been familiar with the stomach bug. We throw up, we have nausea, vomiting, maybe diarrhea, but we begin to seek medical attention when things don't turn around or when they're severe. And diverticulitis can run a gamut between a very mild presentation to something that requires medical attention. So the most simplest way to answer that is if you are presenting with fever, nausea, vomiting, not necessarily vomiting, but fever, maybe some nausea, some loss of appetite, particularly in conjunction with abdominal pain, and particularly pain that's in the left lower quadrant. So when we subdivide the belly, you have the middle portion and the upper, which is the stomach. You have the right upper quadrant, which is the liver and gallbladder. The right lower quadrant is the appendix. Most Americans, Western societies, tend to form diverticula in the left lower quadrant. So the punchline is, I'm having some belly pain and I'm having a little bit of some fevers, and it's really starting to hurt, principally in the left lower quadrant. That's the classic presentation for maybe you have diverticulitis.
So what causes it? I mean, how does somebody get diverticulitis?
Perfect. So I mentioned a moment ago that in order to get the itis version, one must have the osis version. So the distinction is diverticulosis is outpouchings in the colon. Diverticulitis is when those get inflamed or infected. So it's worthwhile to kind of go, who gets diverticulosis? Because in general, most of us do not have those outpouchings. The colon is a tube that digests, and you have the small intestine, the large intestine. But the number one reason why people can develop these outpouchings is as we get older. So think of mechanistic wear and tear. Just like as we all get older, we can develop cataracts, we can develop arthritis, we can develop conditions that require a knee replacement, joint replacement. The same thing could occur in the colon. And without getting too much into the weeds, is still there's still various theories, but the demographics for individuals who are more prone to developing diverticulosis are white, male, senescent lifestyle, meaning lack of activity, obesity, and smoking. And if you look at that epidemiology, there are some things that one can't control, and there are things that one can control. So when you see things like smoking and lack of physical activity and so forth. So that's who gets diverticulosis? It's rare for somebody age 40 and below to have those develop. But as I mentioned, the wear and tear phenomenon, as you get older, there's sort of weakening within the colon, particularly at areas where blood vessels go in, that causes this outpouching to occur. And again, an outpouching is, think of a bubble on your tire. So if you hit a pothole and then you have this area that's kind of weaker and it's ready to pop, that's the scenario in which a diverticula or diverticulosis can occur. So who gets diverticulitis? There are certain risk factors, but very common is Western diet. So the American diet is not ideal for a lot of our health. And so the consumption of red meats and the reduction of fiber in the diet tends to be a predominant risk factor for the development of that. So it's been studied that for individuals who do take attention to modifiable risk factors, they can dramatically reduce their risk of developing infection. One could make an analogy to who gets appendicitis. Appendicitis is usually an infection of younger individuals, and we're not necessarily going to talk about that, but who is more prone to getting that little worm of an appendage in the colon that is vestigial, meaning it's a remnant of our ancestral past. Why does that get inflamed or infected? The same discussion can occur with the diverticula that are there. And so not everybody will get diverticulosis and not everybody will get diverticulitis. But the punchline is, when an individual is older, when an individual is white, male, and particularly with lifestyle factors, the diverticula can develop. And then if the diet is not ideal, then the thinking is that the diet high in animal fats and meats is way more pro-inflammatory and alters the microbiome of the gut. And that interplay between the gut, the diet, the inflammation is where these weakenings and inflammation can occur within the outpouchings.
Interesting. So food was actually going to be my next question, but are there any environmental factors at all that play into this?
Yeah. So the environmental factors, the modifiable risk factors, tend to be our activity level, our weight, do we or do we not smoke, and what kind of foods that we eat. So with respect to itis, diverticulitis, the actual presentation of where I feel the outpouchings causing me to have pain, it's essentially reduction in red meats and increasing in fiber and increasing in physical activity and decreasing smoking and decreasing our weight are all things we want to attain to achieve to kind of reduce our risk.
Interesting. What about it being hereditary? Is that a thing?
Some of the mechanisms for why people develop outpouchings may have to do with what we call the status of our connective tissue. Connective tissue are things like ligaments, tissue that covers our muscles. And the same thing could apply in part to the integrity of the colon. And so there's genetic components that play a role. There was a Scandinavian study looking at identical genetic twins and seeing whether or not it was one-to-one. If one person got diverticulitis or osis, does the identical twin get them? And it's not 100%. So what that says is that there can be a genetic component, but the differences in who gets it and who doesn't is a lot of it is environmental and lifestyle. Exactly. In Asian countries, there is a congenital version where younger individuals are born with diverticulosis in the right side of the colon. I made that point earlier that in the United States, for example, the classic presentation of diverticulitis in an American is an individual who presents with left lower quadrant pain because that's where the majority of the weakening of the colon occurs. But the genetic factor in the Asian variant is where it is occurring on the right side. And that runs more in families than the version that we see in the United States. Is
it something that is becoming more frequent?
Yeah. As a matter of fact, it is becoming a little bit more frequent, and a lot of it has to be driven in part by obesity rates and also the dietary changes that we're seeing in Western countries.
Interesting. So this might seem silly, but is diverticulitis contagious?
No, not at all. So even though it's an infection / inflammation, it's not a communicable disease like one would think the flu or other types of infections that we can get. So if somebody in the household has diverticulitis, no, you don't get it. That's not to say that other people with other gastrointestinal diseases, the most common is viral gastroenteritis. That's certainly communicable. That is highly contagious amongst family members when one person's vomiting and throwing up and having diarrhea in the bathroom, and then everybody in the house gets it.
Yeah, that sounds unenjoyable.
That is not enjoyable. But diverticulitis, once the diagnosis is clear, then and we can get into how that diagnosis is made. Then when you know that it is diverticulitis, it's not contagious. It's there and it's occurring in that individual because they have an inflamed diverticula. Same way as appendicitis, it doesn't spread to others. It's a process that's occurring because of the anatomy that they have and the inflammation that's occurring.
So you kind of already touched on it or brought up the idea of it. I mean, how is it diagnosed? I go in and you're scratching your head trying to figure out what's wrong with me.
Yeah.
Well, hopefully not scratching your head.
No, not scratching our head.
But
maybe a medical student may, yes.
What kind of tests are going to be done in order to determine whether or not I have diverticulitis or what have you?
So the punchline, and then I can clarify, it's typically done by imaging, CAT scan. CAT scan is the prototypical way the diverticulitis is diagnosed. So for those that have never been in a CAT scan, is this donut. It does x-rays and it takes pictures in little slices along your abdomen. And you're actually looking for the actual little outpouchings, and you're looking for, do they look inflamed and infected? And there's specific criteria that radiologists use to make the diagnosis. If you're practicing in an area where you do not have access to a CAT scan, can a presumptive diagnosis of diverticulitis be made? Short answer is yes. A lot of it is the clinical presentation. So you come in and you go, Doc, I've been having abdominal pain. It's in my left lower quadrant. As a matter of fact, I had a colonoscopy 3 years ago and my doc told me they found diverticulosis. I've also had here and there some painless bleeding when I have a bowel movement. That's the classic substrate for somebody who tells you they already have diverticulosis and are now presenting with the right location of discomfort. It raises that as a possibility. And then ancillary testing includes the physical exam. And one of the ways to determine, you have mild or complicated is, are you somebody that's presenting with a serious presentation of diverticulitis that requires hospitalization? The branch points in emergency room medicine or a clinic patient is, does a patient with abdominal pain have a medical belly or a surgical belly? What that means is medical presentations of abdominal things don't require surgery. But one of the first branch points is, are you sick enough where I need to be secure? Do you need to have, you definitely need imaging to confirm what's there. And do I need to have a surgeon come see you because of the way it presents? So in mild cases, if an individual presents in which the differential diagnosis includes diverticulitis in any emergency room, more than likely you will get a CAT scan because you don't want to miss diverticulitis, and you can confirm the diagnosis with the imaging that you get.
So because you don't want to miss it, I'm willing to bet this could be possibly deadly.
Well, it's deadly in certain populations with certain risk factors. So, we've talked about this before. Are you a 20-year-old with diverticulitis, or are you an 85-year-old? So any illness is way more deadly when you add up risk factors such as older age, diabetes, immunocompromise, multiple diverticula that they have, other things such as weakened immune system from advanced age or chemotherapy or whatnot. The clinical presentation is also very telling as to whether or not the patient will do well or do poorly. So best case scenario is, Doc, I've had some mild belly pain. On exam, when the physician pushes on it, it's tender, but there's no concern that you're dealing with like what's called a perforation, where the colon should be intact, but if there's a hole caused by the inflammation, that's more of a surgical type of phenomenon, which can lead to air being leaked into the abdominal space, pus, the whole thing. So those scenarios, as you can kind of get a sense, are more serious. And so how can you predict whether or not someone will die from diverticulitis? The more severe the initial presentation or how it continues to evolve, is there a higher propensity for that patient to succumb to that illness? It can be upwards of 20% for individuals who develop an abscess. An abscess, think of it like a really large zit that there's pus, but it's within the colon. When there's an abscess, particularly if it's 4 centimeters or larger, that is a scenario that requires drainage.
Jeez, that sounds massive.
It sounds, yeah. But the majority of cases for diverticulitis are mild to moderate. And one should not expect that if they're diagnosed with that they need to worry tremendously. But just like any other presentation of any illness, when you stack up the clinical presentation plus the imaging plus the labs, the moment somebody has a presentation of diverticulitis that is more severe at the time of presentation, ergo, a surgeon needs to get involved. That's usually an individual who has a rougher presentation, and therefore they could not do as well. But in modern medicine, we have antibiotics, we have fluids, we have surgery, et cetera, and we can get into that treatment in a second.
Is out of curiosity, of diverticulitis caused by, or does it cause any kind of mental health issues? I mean, could stress bring it upon or anything like that?
Well, the short answer is no. The long answer is emotional stress, environmental stress, physiologic stress. The social determinants of health is kind of what you're alluding to, in which mental health is part of. So if you are financially secure, have a house, have no mental health diagnoses, do you tend to have less medical diagnoses? The short answer is yes, you have less. So if you are emotionally stressed or have mental health issues, is there a one-to-one correlation? No, but the connection could be that if one has untreated or uncontrolled mental health, could there be associated risk factors that are more likely to contribute to what we see correlates? In other words, does less physical activity correlate with mental health? It can. If you're depressed, are you more likely to go running versus staying at home and not doing that? So the short answer is yes. A lot of substance use goes hand in hand with mental health diagnosis. So there are certain correlations, and it's not entirely clear why, but the use of certain medications chronically, like aspirin, nonsteroidals, or even opiates. Opiates, as we know, with the opiate health crisis, fentanyl and so forth, it impacts gut motility. And part of the principle why these outpouchings occur is that certain drugs, if an individual is more than likely to utilize recreational drugs like heroin or opiates that impact the gut because they're self-treating their mental health diagnosis, are they more likely to develop diverticulosis or diverticulitis? I'm not 100% of that answer, but the sequence that could lead to that could be. But it isn't a clear-cut one-to-one. If you have schizophrenia, that equals more diverticulitis? No. That's not true. If you have depression, that equals more diverticulitis? No. But what we do know is being male, being white, smoking, being obese, having a Western diet with more red meat than you should, and consuming less fiber in your diet can certainly contribute. And the connection between that and mental health, is there more tobacco use or recreational drug use in untreated mental health? The short answer is there tends to be. But it isn't a one-to-one risk factor. So I wouldn't tell a patient because you have major depression or bipolar disorder or schizophrenia, oh, we got to watch out, you're going to get diverticulitis. That's not true.
It's just the lifestyle itself.
Correct. Yeah.
Okay. So how, you kind of spoke about this, but I want to get into further into diagnosing it. Like, how does a doctor or a clinic or whomever test for and determine that someone has diverticulitis?
So with any patient evaluation, we're all trained to take a story, do an exam, and then do ancillary data. And 90% of diagnoses in general can be made by talking to a patient and actually examining them. And I teach a lot of medical students, and I always try to tell them, can you make that diagnosis without sending that patient to the lab or sending them to x-ray? And 90% of the time for most diagnoses, you can. So the diagnosis is made presumptively. It sounds like you've got diverticulitis, but in order to confirm it, then you need to do additional tests, which include blood tests. Blood tests include checking. The simplest blood test that's very useful is a complete blood count. You're looking for an elevation in the white blood cell count. White blood cells normally are 5 to 10,000 per cubic milliliter of blood. When they're higher than that, they're indicative of inflammation or infection. If you're coming in with focal belly pain in your right lower quadrant of your abdomen, and it sounds like, that's in the right location for diverticulitis. In the clinic, you have a fever. On exam, I push on your belly and it is tender. And as a matter of fact, you're a little bit rigid, meaning your belly is spasming to kind of protect me from pushing on it. And then I check an elevated white blood cell count. I pull the trigger on getting a CAT scan because that is so classic that we need to confirm it with the CAT scan.
Okay. And is there a way to catch diverticulitis early? I mean, not actually get
not
it,
contagious, but identifying it early. Yeah. Well, just like with any diagnosis, the pattern of presentation may throw you off in the beginning, but then it begins to declare itself. So if you have intermittent mild right lower quadrant pain, and you were calling me and you're like, doc, should I go into the emergency room? I would be like, do you have fevers, chills? How's your appetite? Are you noticing blood in your stool? Can you push on your belly and does it really hurt or is it mild, right? I can triage you and go, could this be the early presentation of diverticulitis or not? And so sometimes we get it wrong, but we're always erring with diagnostic imperatives, meaning I can't miss this diagnosis in you. And if I do, you could die or you could sue me or whatever. So how do I catch it early to make the diagnosis? It really comes down to the index of suspicion that you're more than likely to have this diagnosis and you should come on in. But it really comes down to the pattern, right? So if you're having right lower quadrant pain one day and then the next day it's gone, and then 2 days later it's back, and then the next day is gone, that is inconsistent with diverticulitis. And how do we know that? It's based on the pattern of presentation. In medicine, when we make diagnosis, we always look for the cardinal signs and symptoms of a diagnosis: onset, provocating, palliating, quality, severity, timing of an illness. And does it fit perfectly within that, or are there things that don't quite fit? So the short answer is, when it's obvious, and it may not be too late. It may just be very clear and very obvious to even a lay person. Oh my God, you need to go to the emergency room. Versus somebody in which it's subtle. So what do we recommend patients? Again, I'm not being alarmist and I don't want to alarm anybody, but whenever symptoms are there that an individual goes, God, this is hurting and I don't really know what it is, then it's fine to get checked out, because it's always worthwhile to see if that's present or not. Does making diagnoses earlier than later impact outcomes? Yes, it can. If you are presenting with chest pain that sounds like it's blockages in your coronaries, or you're presenting with stroke-like symptoms and you're letting that last for several hours to a day or more, it's a little late in the game to come on in. And so when there is diverticulitis, if caught early, are you preventing the perforations, the complications? Are you preventing the abscess formation? You can. So when in doubt, seek medical attention, particularly when, we're all, for the most part, pretty savvy at going, this isn't going away. This is kind of there and it's worrying me. That's usually a pretty good gut instinct to get checked out.
Are there things that present just like diverticulitis?
Yeah. So a variety of GI issues. So the most common type of gastrointestinal issue that people get are things like food poisoning, ingestions of bacterial organisms like E. coli from undercooked hamburger, what have you. And those are presenting with the classic diarrhea and nausea and vomiting. And can those present with pain as well? The type of pain in those more common clinical scenarios is more diffuse. And so when we examine a patient, if the discomfort is diffuse throughout the belly and it's not focal, it argues a little bit against diverticulitis. But the two can mimic each other, because whenever the bowel is irritated, it can hurt because it's spasming. The pain in diverticulitis is the type of pain that people get in appendicitis. When it starts to get inflamed, it becomes very focal because you've got a zit, so to speak, that's in the colon that's now irritating the inner lining of the belly. That's why it's so focal, that the moment it's focal, then it starts to become more diverticulitis. Earlier in the stages of diverticulitis, somebody could be presenting like, I think I ate bad meat and I'm having diarrhea. And then when the patient is examined, they're like, you're kind of, there's some focality or tenderness. Most of those folks in the emergency room do get a CAT scan because there are other things. There's C. difficile diarrhea, there's infectious colitis, there's other diagnoses that are completely non-infectious, ulcerative colitis, Crohn's disease. These are within the specialty of gastroenterology. But the more common things occurring commonly for most individuals are bacterial infections related to ingestions that are presenting with abdominal discomfort and diarrhea. Very nonspecific until it becomes focal, in which diverticulitis becomes more obvious. Yeah.
Interesting. Learning a lot today. So diverticulitis, how is it treated? Or, I mean, if it's not even moderate, will it, take care of itself? Yeah. Or no matter what, do I have to get some meds or something else?
Yep. So I'm an infectious disease physician, and I'm just prefacing this answer by saying that the latest approach to diverticulitis, ergo itis, infection, inflammation, one would think antibiotics, but is this self-limited in some people, and can you treat it without antibiotics? When I was in training couple decades ago, the principle has always been to treat with antibiotics for as long and even longer for most infections. The short answer is, for mild cases, let's say you're young, you have no diabetes, you have no immunocompromise, you're not on any medications that weaken your immune system, you present without a high fever, your white blood cell count is not that high, your exam is kind of meh, it's mild, but you're not presenting like in what we call extremis, where it's so severe and you're in septic shock and you need to go to the ICU. And we do a CAT scan and you see that you've got that. Or not, I could triage, in which I say rest, plenty of fluids, clear liquids, advance to tolerate as tolerated, and pain medication. Can you, in the next 2 to 3 days, it goes away? Yes, it certainly can. So the algorithmic approach is that with shared decision-making and clear instructions, if it's mild on presentation, best case scenario is the patient's given a prescription for pain relief. They're given some bowel rest, meaning avoid eating massive quantities of food. Just give your gut some time to rest, and then advance your diet in 2 to 3 days from liquids to more formed foods. In 2 to 3 days, if your symptoms are gone, great. Now, the other scenario is the potential for, does that patient require admission? And how do we decide when a patient should be hospitalized or even be seen? So if you go to the emergency room and the doc goes, you need to be admitted, some patients go, really? Or some people know intuitively that they're sick enough and they actually want to. When somebody is admitted, those are individuals in whom the treatment involves systemic antibiotics. So through an IV, sometimes some of the ones that we use can be absorbed through the gut just as well as IV, but when the gut is irritated, it's best intravenously. And then it's serial exams, serial vital signs, serial labs to see if you're heading in the right direction or not heading in the right direction. Because what you want to do whenever there's inflammation can coalesce to an abscess, a pus pocket that now verges on, that colon is a little bit more likely to rupture or a little bit more likely to develop more pus. That's going to get that person sicker and put them in the ICU. In most cases that I've clinically seen, and the majority of people who have diverticulitis, they come into the hospital, they get IV antibiotics, they clinically get better. It's the individuals that present in which in the next 24, 48 hours, they get a little worse. Those are the folks in which the surgeons come in. I'm not a surgeon, but we call surgery because the approach becomes, is it just bowel rest, fluids, IV antibiotics, or is it that plus surgical resection of the area that's inflamed? Just like appendicitis, do you need an appendectomy? Do you have to have the appendix removed? And the same clinical decision-making applies to diverticulitis. Most cases of diverticulitis are no longer algorithmically leading to bowel resection, except in cases in which it's indicated. So there is a perforation, there's an abscess, there is something called fistulization, where the colon itself can start creating little offshoots into other portions of the body. That's a little hard to describe in such few words. But those are made by clinical assessment and sometimes repeat imaging. And a lot of times we're really heavily reliant on the surgical evaluations. As a hospitalist internist, whenever I call surgery, I want them to be secure. Do they or do they not need surgery as part of this presentation? Again, the majority of people who develop diverticulitis who do get hospitalized do not require surgery.
So if I have diverticulitis, what should I do or what should I not do? So
again, we talked a little bit about if you're given the diagnosis of diverticulitis and you're sent home, if you're given a prescription for antibiotics, complete the antibiotics as directed, typically 7 to 10 days duration. You would be given recommendations on the types of diet to eat. And then monitor for signs and symptoms. Your doctor may say, continue to check your temperature. If you're elderly and you're still pretty well compensated, sometimes there may be visiting nurses that come by to assess, but not necessarily so. So if all goes well and you complete therapy, then if you've never had a colonoscopy, people that have had diverticulitis should get a colonoscopy to surveil what's up with the colon. We need to take a look in the colon once everything subsides to make sure that that was just diverticulosis that got infected versus something else that the CAT scan may not have seen. And so the recommendations are always, that's part of screening to kind of ascertain, oh, it's worthwhile to take a look. That's there. And then if you really want to dramatically reduce further episodes, because when people have a first heart attack, they don't want a second. When people have a first stroke, they don't want to get a second one. So the same thing goes for this. The conversation with a patient, what should they not do is if they're smoking, they should quit smoking. If they consume too much red meat, reduce that. If they're not consuming as much dietary fiber, increase that. If they're physically inactive, increase that. Those are some of the things.
And so generally, I mean, it sounded like a week or so, in at least for mild and moderate cases, it should resolve itself within a week, maybe?
Yeah, typically a week to 10 days. For the complicated cases, that is not that common. The cases that I see, if there are individuals requiring surgery, it's highly, highly, highly variable. It depends on the complications that are seen. Is there bacteria that slip into the bloodstream? Are they requiring ICU care, needing blood pressure support, ventilator support? Those are people that you can see that in a variety of other clinical diagnoses where they're that sick. That is a rougher course and obviously longer recovery. But for most uncomplicated diverticulitis, we're dealing with anywhere 5 to 7 to 10 days for complete resolution of symptoms.
And is diverticulitis something, I mean, if you have diverticulosis, then it's possible to get diverticulitis once, twice, or more?
It could, yeah. So approximately, I believe 60% or so of individuals who have their first episode of diverticulitis can get it again. The severity is not any worse. So with certain illnesses, sometimes the second time is worse, but with diverticulitis, if you get it again, it isn't of that nature. But then subsequent cases may taper off. So if a patient were asking me, Doc, am I going to get this again? You can have a 75% reduction in you getting again if you modify lifestyle. That's been pretty well documented. So this is one of the things, just like diabetes, high blood pressure, osteoarthritis, a number of things are how we live through life. Like, what do we eat? How do we move? How do we sleep? Et cetera, et cetera. So if one wants to reduce the risk of that, that's a recommendation that would occur. For individuals that get it again and again or have huge numbers of diverticula and multiple admissions for diverticulitis, then the discussion is, does a surgeon preemptively resect that portion of the colon that's misbehaving? And that's shared decision-making with the patient, because the short answer is it, if you remove the appendix, guess what? No more appendicitis. If you remove the portion of the colon that keeps getting inflamed or infected, the goal is no more cases of diverticulitis. But not everybody necessitates that. And that really comes down to a variety of factors that weigh in on that approach. So it can recur, but again, it's modifiable.
And so if somebody's diagnosed with diverticulitis, I mean, we obviously less symptoms, then things are getting better. What are the things that people would be like, hey, I definitely, all right, now this is bad?
Yes. So from a clinician's vantage point is, are they having a surgical belly? And from a patient standpoint, what that means is, this hurts so much that every step I take, meaning I'm jiggling my belly, it hurts. That is classic what's called peritonitis, meaning the peritoneum, the lining of the abdominal wall, has been breached by a diverticulitis that is now popping or creating pus in that space. So from a patient's perspective, this is hurting like crazy, and it's actually hurting even when I move around, because that movement is what's signaling to us that this is not a contained infection. This is an infection that's starting to spill and irritate the abdominal muscles, that when you move or you jiggle them, that's classic presentation for somebody that has peritonitis, the condition in which the infection is really bad. So any sustained high fever, again, if you are an individual who has a lot of medical issues that you see doctors for, you're no longer 18 and healthy, you're 75 with a lot of medical issues, particularly if you have diabetes, you have, you're taking medications that are immunosuppressant, immunocompromising, your substrate, you're more likely, because you're older and you have all those things, to do worse than if you were 18 with a similar presentation. So those should, how is it presenting? Is it really bad? And then who am I? Am I somebody in whom this could get worse? So again, if you're an individual that has a lot of medical issues, that's the general punchline for most illnesses. It's always preferable to nip it in the bud or to get checked out and seek attention, because statistically speaking, you're more prone to doing worse.
Well, here's to hoping I never get diverticulitis.
Me too.
Man, but for all you out there in the audience, you're looking for more information, we've got a link in the video description below. Doc, thanks as always.
My pleasure.
Hey folks, connecting with your benefits is our primary mission, and the SITREP is providing more options than ever.
Subscribe to our free email newsletter, subscribe to our audio podcast channel, or subscribe to our content on YouTube.
For details and links, check out the description below.